Good morning and welcome to this webinar hosted by the Open Society Foundation for South Africa and the Bhekisisa Centre for Health Journalism. My name is Mia Malan, Bhekisisa's editor. As the name of our webinar suggests, we're going to focus on one of the most talked about and contentious issues in the world right now, vaccine justice, and how those countries with the most money get to buy the right to healthcare and in effect survival first. We've got a panel of 6 really formidable panelists lined up for this discussion, and our webinar is going to be about an hour and a half, and here's how things are going to work. We're going to start off with brief opening remarks by OSF South Africa, and then I'm going to ask each panelist a question to which they will have about 5 minutes to respond. And then we'll move on to a Q&A session during which I will pose your questions and comments to the panelists to respond to. So if you're joining us via Zoom, please do enter your questions and comments in the chat box. And if you're joining us via the Facebook live stream link, you can leave a comment or a question on the OSF South Africa Facebook page. We'll keep an eye on that. OSF South Africa will be live tweeting this event. If you wanted to retweet them, their Twitter handle is @OSF-SA, and if you'd like to do your own tweeting, we've got 2 hashtags that you can use. One is vaccine justice and the other vaccines for all. We've also just dropped these hashtags in and the OSF and Bhekisisa Twitter handles in the chat box on Zoom so that you have it all on hand. And now I'd like to introduce Maxine Case, who is the head of communications at OSF South Africa. She's going to make some opening remarks. Maxine? Maxine, are you there?
Oh, sorry, Mia. I see I was talking, but I had not unmuted myself. So thanks again, Mia, and thank you everyone for joining us. We had planned to hold this convening much earlier in the year, which we thought would coincide with the rollout of our mass vaccination campaign in South Africa. Unfortunately, that has not happened, but it allowed us to catch up with the conversation. So initially, when we designed this convening or conversation, we thought that what we really were going to address was the issue of vaccine hesitancy. However, the more the year has progressed and the more we spoke to people, we realized that vaccine hesitancy is a luxury that maybe more developed countries have, countries with more extensive rollouts, and that we can't divorce the issue of a vaccine rollout, therapeutics, etc., without looking at vaccine equity and vaccine justice. So we realize at OSF-SA that we don't have all the answers, but we would like to see people understanding the need for to become vaccinated and all the issues around impediments to that. And we realize that access and lack of information are also crucial. So we've called together experts in the field, and we've been so lucky to be guided by Mia, who's been a fount of information on the subject, as well as our colleague in New York, Ahmed, who also speaks widely on vaccine justice. He won't be able to join us live, but we will be sharing a video from him, as well as all the other panelists. So thank you so much, and we'll leave it to the experts now. Thank you.
Thank you very much for that, Maxine. And just to add what Maxine has said, many of you may have seen our very high number of daily cases that was released last night, over 13,000. And our positivity rate, which is the proportion of tests that come out positive, was extremely high, over 17%. On the same day, New York City recorded a record low positivity rate of just 0.36%. Why? Because they have managed to give 70% of the population at least a first shot of a COVID vaccine, compared to South Africa, where we sit at 3%. And I think that is a very good example of where we are at with vaccine justice at the moment. which is where I would like to introduce our first panelist, which is going to be Nono Makhatu, who is the Executive Director of Africa Check, which is the continent's first independent fact-checking organization. Nono, you work in the media industry and you deal with mis and disinformation on COVID vaccines daily. What's the media's influence on people's uptake of vaccines and how accessible they are?
Thanks, Mia. So there's a real challenge in the communication around the vaccine, particularly around increasing public access to good information, which should really be the key element of a successful vaccine rollout. And we see that people are vulnerable to misinformation, particularly in times of uncertainty. And also there's low trust in media and in authorities, which is also linked to increased vulnerability to misinformation. So we're quite concerned that we could have a situation where vaccine hesitancy is an issue in the South African context at some point, because there's a lot of misinformation linked to the vaccine that is out there, which could lead to devastating outcomes. And so it's clear to us that information about vaccines needs to come from credible, trusted sources with authority. The communication must be clear, easy to understand, and updated on a regular basis. So what is clear is that the health authorities need to take the lead in providing information about vaccines, information that is well researched, written, and approved by subject matter experts. And this work can be done in conjunction with physicians, researchers, epidemiologists, and analysts. The content would have to be peer-reviewed, based on peer-reviewed science. So the leadership of the health department is crucial in putting out good quality information. And there's a collaborative effort that needs to take place between healthcare providers, public health professionals, educators, and researchers. So credible information alone is not enough. The information source and the communicator making this information available also must be deemed to be credible and be an expert and be trustworthy. So we have seen that misinformation often takes advantage of topics that are difficult to understand by non-experts. So a recent study showed that trustworthiness is more important than expertise when it comes to vaccine misinformation. Health professionals are among the most trusted sources of health information, and so they should lead the charge in pushing the vaccine. So the best approach dealing with misinformation is good information on topics that are vulnerable to false claims. And we call this pre-banking, publishing accurate information before inaccurate claims start circulating. It's also important that this information be made available in different languages and be published beyond the online spaces and into the offline spaces as well, as we have a large digitally unconnected community. So the other thing that's important is misinformation literacy efforts or media literacy efforts. These are important to empower the public, particularly the youth, with the knowledge of the forms of misinformation that is out there, the processes by which they are produced and emerge or are distributed and consumed, and the skills to distinguish bad information from good information. Ultimately, evidence-based interventions can help debunk and pre-bunk potentially harmful misinformation. So this requires fostering strong relationships between the professional media, social media platforms, health professionals, and trusted actors. Thanks, Mia.
Thank you very much, Nono. Those are really interesting insights, and thank you for pointing out that we need information in all languages and not just English, particularly in South Africa going around. And also for the important role that the health department needs to play in distributing information. And I think that's one aspect that people have different opinions on how effective they currently are with that role of communication. But we're now going to move on to someone who does communicate really well, particularly on social media, Dr. Tlaleng Mofokeng. And she's a medical doctor and also a special rapporteur of the United Nations Human Rights Council on the right of everyone to high quality health services. Tlaleng, as a medical doctor, what do you hear from patients about the accessibility of vaccines? And in your work as a special rapporteur, which vaccine justice issues have come up?
Thanks, Mia. I decided to go back to full-time clinical practice, around about the time that the special rapporteur role, the appointment happened. And that was also at the time in South Africa, we were starting to deal with the reality of the pandemic, right? And it's been over a year since the pandemic took over the world, and as a shock, literally, to all of our systems, right? And it was an opportunity to band together to display true solidarity, of course, between nations, right? But also, I think, even within districts, within the health facilities, often when we speak about solidarity, it's something that we're always expecting of member states and of those in leadership and in governance. But I think as healthcare providers, if you think of the many struggles that people experience with access to protective personal equipment, for example, the difficulties that doctors and nurses were facing in terms of diagnostics and treatment within hospitals, but also the amount of work that then fell on the lap of community healthcare workers, who had to go into the communities, firstly to tell them what COVID-19 is, again, in languages that people understand. But we remember that community healthcare workers in this country had been fighting a long battle to be recognized as full-time healthcare workers and part of the healthcare force. And it took COVID-19 to really show the point that many of us had been making all along, that it's only when you have a strong community health system and an efficient primary healthcare system that you can really, really, truly have a direct impact onto the rights holder, in this case being patients. And healthcare workers, when I presented my first statement to the General Assembly in October in 2020, and I described how it's so important to look at the health and well-being of the healthcare professionals, because under any other circumstance, we were already at the brink, we were already at the edge. Even within our own industry, we are marginalized by policy decisions. We are not on the table when decisions are made about procurement, resource allocation and spending. And I always say, the complaints that patients have about having to get healthy and well in dirty hospitals, where there's smelling, where there's poor nutrition, where there's poor access to water and sanitation, that is our workplace. And as part of the right to health, even as healthcare workers, we have a human right under the right to health, to healthy working environments. And so we are actually all worried about the same thing. It's just that healthcare workers are the face, right, of the system, because we are hired by government to perform our duties. But many healthcare workers have no power or authority to make any decisions, let alone bed allocations when patients come, right? It's always a managerial issue that has to, and that hierarchy in medicine sometimes, I think, impedes patient care. But I can tell you that doctors and nurses are not okay. Mental health wise, people are completely strained. We have a colleague in Kenya who died by suicide, who was a doctor and who had been working in one of the Kenya's bigger institutions. And so these issues don't just only impact South African healthcare workers, but it's a regional, international issue. It's just that in some instances, people do have, better protections in terms of their employment. For example, if you're a community worker, you can't just take leave because your mental health is taking strain when even your employment contract is not fair and just in terms of labor practices. So when nurses and doctors even had symptoms of COVID, in some instances, they were demanded to come to work, because if they didn't come to work, their entire clinic would collapse and there would be no service. So not only are they trying to assist and deal with patients, deal with the inadequacies of the past that COVID-19 is compounding, but they are now breaking bad news about bereavement, right, to loved ones. In such it's unimaginable how people are coping, but they then still have to deal with unfair labor practices and the lack of enough nurses and doctor to the population ratio. And just to just say that we'll speak about the vaccine and the fact that some nurses and doctors are still not vaccinated. But what's also important is to, especially for the South African perspective, widen the definition of a healthcare worker. Because you have security guards, right, who are also on the front line because they have to make the physical facilities secure. You have clerks and administrators who do not see patients, but they are the ones, in fact, who see patients before we can even triage them, right, and decide where they need to go. It's the clerks who see those, the cleaners in the hospital. So we need to widen our definition of healthcare workers in South Africa. Otherwise, we run the risk again of leaving people behind and perpetuating inequalities in an already a situation that's existing of inequity when it comes to vaccine rollout. And I think that's important. So as we talk about how many nurses, how many doctors received vaccine, let's think about community healthcare workers, and let's think of other allied healthcare professionals like physiotherapists, like dentists and so on and so forth.
Thank you very much, Tlaleng, and thanks for pointing out that the unfair labor practices and unfair contracts of particularly community health workers in South Africa relates as much to vaccine injustice as the inaccessibility of vaccines to poorer communities does. So thank you for your insights. We're now going to hear from someone who is a specialist when it comes to ethics of health issues, and that is Professor Ames Dai, who is a specialist ethicist at the Office of the President and CEO of the South African Medical Research Council. She's also the founder and past director of the Steve Biko Centre at the Faculty of Health Sciences at Wits University. Ames, how ethical is it for countries such as the United States to start vaccinating teenagers already when Africa is still struggling to get jabs for its most vulnerable population of people of 60 plus? And how do issues such as vaccine passports and access to vaccines for migrants and refugees and disabled people perpetuate vaccine inequity?
Good morning, Mia. Good morning to the panelists and the delegates, and thank you for having me in this, I think, such an important activity. So I think what hasn't actually been emphasized adequately when we look at vaccine access and equity globally, and this will, will answer the questions that you've posed, Mia, is the moral responsibility of states and the moral responsibility of the citizens of states in the race to equitable access to vaccines. The question that we need to ask is, can this public health crisis be solved without vaccinating all the citizens of a state? Do we need to vaccinate all of them, even including children and young people, to solve the pandemic in a state? We know that some states have bought up and are currently buying much more numbers of doses than they need for their own population, without allowing the sharing with developing countries. And also we have heard and we know that many developed countries are now going to vaccinate in the short term children instead of enabling these doses to be made available to us in our developing countries. So the question is it ethically acceptable to vaccinate all the populations in a country, even when the countries have reached herd immunity or so-called herd immunity, instead of enabling vaccines to be shared globally? I think it's morally reprehensible that we've actually reached this situation in the world. You know, we've always pointed fingers at big pharma, and we brought in the TRIPS issues, and we emphasized that big pharma is holding the world hostage. But I think we haven't said enough about the moral responsibility of these states and their citizens, because I don't think their citizens are making adequate noises and actually see themselves as brothers and sisters of the, in a global village, of everyone in a global village. The problems that I see it is not only about patents, and I'm going to bring in the TRIPS here, but it's about production, distribution, and sharing. For me, very important, sharing of vaccines. Instead of vaccinating groups and individuals without a real risk of COVID. Now we're talking about, should states be vaccinating children while elderly haven't been vaccinated? But turn the clock back to January, February, where states had been had already started vaccinating young adults, when healthcare workers in Africa were dying of COVID-19. So I think from an ethical perspective, the problem is that of distribution, because there is enough vaccines for everybody in the short term and the middle term if states change their way of acting currently. I have emphasized moral responsibility of states generally. I also think we need to look at the moral responsibility of heads of developing countries and their moral responsibilities towards us citizens in terms of handling the situation properly. I'm not going to go into detail on this, but I don't think that we cannot think or discuss the corruption issues that have been plaguing the pandemic ever since we started. In terms of not only the over 60s, but in terms of our, refugees, displaced migrants, etc. It's very important to realize that the World Health Organization makes a very important statement. No one is safe until everyone is safe. So one can use a utilitarian argument with regard to including them in the vaccination programs so that everyone can be safe, even the privileged. The privileged will not be safe until everyone is safe. And we can see this in the states where, while they've reached about 70% immunization or first shot of vaccine, there's huge concerns because of the Delta variant now coming in. And we will continue seeing these variants circulating until we look at vaccines as a public good. And we actually recognize that vaccines, the world stops paying lip service to vaccines being a public good. Mia, do you want me to continue or?
You can continue for another 2 minutes if you would like to, Ames, yeah.
Okay, so I just want to move on to vaccine passes or passports or vaccine certificates. And while countries have immunized about 70% of their populations, they've started quickly moving to vaccine passes to allow global travel and to allow travel within the countries. And definitely this is important in terms of opening up, in terms of civil liberties and also opening up the economy. In terms of vaccine passes, health certification for vaccine purposes have already been in use with regard to international travel, for example, the yellow fever. But we don't have real guidance for its ethical implementation in COVID-19, and especially in the South African context. And you know, South Africa follows the West. And there's already been some talk about South Africa developing or getting onto the vaccine passport trajectory. I think it's very important, if we're looking at vaccine passes in South Africa, we look at the issue of cooperation between local people in, between the various local levels within the country, but we also look at a multilateral approach. And there's also, I think, if we look at vaccine passes globally, there's got to be international cooperation. The question is, without adequate access to vaccines, and with a country like South Africa only having 3% of its population having the first shot, is the globe ready for vaccine passes? And is South Africa ready for vaccine passes? So who's received out the vaccines? Healthcare workers and over 60s. And would it be fair to the rest of the country for healthcare workers and over 60s to actually enjoy the privileges of having a vaccine pass, as compared to those that have not been vaccinated? Thanks.
Thanks very much, Ames, and a really interesting issue that of vaccine passports. I see the many European countries this morning opened up travel for people from the US again, but only with a certificate to show that they've been vaccinated. So it's interesting to see where that will take us. And thank you also for pointing out that vaccines are public goods, and we will not get through this pandemic until the entire world has the ability to get vaccinated. We're now going to hear from Dr. Lauren Paramoor, who is a senior lecturer in the Political Studies Department at the University of Cape Town. She's also a member of the People's Health Movement in South Africa. Lauren, countries such as South Africa are calling for a waiver on intellectual property rights for COVID vaccines and also treatments. And meanwhile, the only way for poorer countries to access vaccines are through mechanisms such as COVAX. How far will a waiver really get us? And what are the limits of mechanisms such as COVAX?
Thanks, Mia, and good morning to everyone. So maybe just to say as a point of departure that two principles are central to the work of People's Health Movement. So the one is that everyone has the right to the highest attainable standard of health. And then the other principle which goes along with that is that, of course, that right is, we believe, it's an effect of certain social determinants. So in other words, health is not necessarily only a biological condition, it's also something that's socially determined. And what that means in simple terms is that one's access to money, power, and resources determine to what extent the right to health is realized. And so I think, given that point of departure, the TRIPS waiver is really, really necessary. And I'll say a bit more about why that is the case in what follows. So I think, if you look at the international context, certainly there's a huge distortion in how vaccines have been distributed. And so we know that the bulk of vaccines are available in the global north, in so-called developed countries and wealthy countries. And one of the reasons for that is money. So we know that states in the global north have far more resources than states in the global south. And this, in part, is what allowed them to secure vaccines even before they had been proved efficacious, right? So we know that many states in the global north, if you want pre-booked access to vaccines, on the understanding that if experimental vaccines were to prove effective, that they would have the first place in the queue in order to purchase these vaccines. So I think that's one very simple and stark illustration of how money, access to money, shapes the right to health. In the case of power, I think, and here we come to the issue of TRIPS, which regulates trade-related aspects of intellectual property rights. So the TRIPS agreement, on the face of it, is supposed to promote public welfare. That's in Section 7 of the agreement. It's supposed to promote tech transfer. That's in Section 8 of the agreement. And then, of course, we also know that in 2001, the Doha Declaration was issued, and that was as a result of huge pressure by the Africa bloc of the WTO, but also HIV/AIDS activists. And the Doha Declaration states that in keeping with the TRIPS agreement, that states are allowed to defend the right to health, particularly in public health emergencies, and that this should entitle them to use flexibilities within TRIPS. So, for example, compulsory licenses and parallel imports. So, you know, on the face of it, there is a legal right to the right to health, and on the face of it, TRIPS shouldn't impede this legal right. But of course, we know that one of the key social determinants of health is power. And so in the context of a highly unequal international system, in effect, TRIPS has been implemented in a manner which, by and large, ignores these public health aspects of the agreement. And in fact, developing countries in the global south are severely penalized when they try and use TRIPS flexibilities. And it's in the context of that kind of political imbalance that South Africa and India in October 2020, and subsequently supported by a number of other countries, including the US, at least on the issue of vaccines, have applied for a TRIPS waiver, because the idea is that even though on the letter of the law, countries should be able to utilize TRIPS flexibilities in a public health emergency, politically, often that isn't the case. They suffer huge levels of retaliation. And so a TRIPS waiver that suspends IP provisions on diagnostics, therapeutics, and vaccines creates legal certainty that allows global South countries to cooperate, that allows a measure of tech transfer, and hopefully these mechanisms are first steps towards building up local manufacturing capacity in the global South, and in the absence of legal risks that might exist if the waiver wasn't passed. So, I mean, I think also one of the key things to kind of think about in terms of TRIPS, and this is in a longer historical context, is that TRIPS was only passed in 1995. And so before that, the intellectual property rights frameworks that many states adhered to were matters of local authority, so national authority. And each government would decide on the kind of strength of patent protections, for example, or would decide whether these protections would be applied to medical products or medical manufacturing processes. So I also think, you know, in that kind of broader historical frame, it's important to keep in mind that the strength of IP provisions under TRIPS is historically new, that historically and for a much longer period, IP provisions were not necessarily applied to medical products. And certainly also in this long frame, the understanding was that IP provisions should be used in a manner consistent with public health interests, that it shouldn't be something that is considered good in and of itself. And so I think that's the other important consideration to keep in mind, which is and not necessarily the realm of manufacturing or legal interpretation or politics, but also the realm of ideas, right? And how we think about IP and for-profit markets in relation to public welfare. I think also one thing to keep in mind, and maybe this is a little bit of a segue, but also locally, certain social determinants of health are very, very important. I think other panelists have touched on this. And so I think it's important to keep in mind that even if access to vaccines were secured in terms of broadening the manufacturing base, it's important to keep in mind that locally there are huge inequalities between the public and the private healthcare system. And so I think in this respect, it is commendable that the South African government has been quite strong on the fact that it would be the sole entity procuring vaccines in order to make sure that presumably the best available price could be secured. We don't really know because a lot of those agreements, the details of them are not known. But I think the other important thing is that the government has taken a strong stance on making sure the same protocols for accessing vaccines apply across the public and the private sector. And I think that's important because that need not necessarily have been the case, and there could have been huge distortions in terms of access to vaccines. Basically, people could have accessed them on ability to purchase rather than on the ability of medical need and age. And so I think those are important things to acknowledge. Thanks, Mia.
Thanks, Lauren. You made a very powerful point about power being one of the key social determinants of access to healthcare services. And that brings us to our next speaker and panelists who will be able to expand on this more within the context of the power of G7 countries when it comes to decide about who has patents and whether intellectual property rights can be waived or not. Dr. Moga Kamal-Yani is a senior health policy and programming advisor for several international health and development agencies and also governments. Moga, there are limits on who can manufacture vaccines and as a result, who can access them first. And the G7 countries have so much power in World Trade Organization negotiations. How do we address that and move forward? And also, how do we use that to prepare for future pandemics?
Good morning, and thank you for inviting me to this really important webinar. Just before we talk about the G7, the stark inequality is not inevitable, as you know, and therefore we shouldn't accept it. And that's what the People's Vaccine Movement is doing, is basically not accepting what's happening now, the status that we're in worldwide, and trying to change the powers, try to influence these powers that we talked about, rebalance what's happening in the world so that everybody can benefit. So the G8 was, I mean, I can't say that I expected better from the G8. It's just I had hoped, or we all had hoped, that they will turn the words into some action. So this thing of nobody's safe until everybody's safe, oh, it's a global, blah, blah, it's solidarity, we need solidarity and whatever. In reality, that didn't materialize at all. All we had is some promises of some donations, which will materialize next year, by the way. So how many people are going to die until this donation materialize, which are very small donations, really, compared to the huge demand on vaccines. But anyway, so we're not getting anything now, basically. So there's no commitment on the TRIPS waiver that colleagues talked about. There's no commitment on sharing knowledge, sharing technology. There's no commitment on that. Bit of money, I guess, and bit of donation, and that's it. They've done tick, we help developing countries. The reality is, if this is even from a pure self-interest, this is really short-sighted. Because as we know now, we have the Delta variant, which is causing, to be honest, quite a lot of worry here in the UK, given that they have achieved successful vaccination program, vaccinated around 60% of the population, but they're really worried about this new variant. It is still affected by vaccines, but not to the same level as the old variants, if you like, or the original virus. So if you're worried about that for your own people, do something about it. But the something is, let's have more vaccines, let's have more boosters, let's vaccinate kids. So again, inward looking and not really looking at, we have to vaccinate everybody in order to protect ourselves here. They're not seeing it that way, even from a pure self-interest perspective. So what the People's Vaccine is calling for, we're calling for a global plan to vaccinate everybody, basically, in the whole world. The thing is, it's not the situation we're in now. It's not a surprise. It's not something unpredictable. We have lots of people to vaccinate. Wow, didn't we know that there's 7 billion people on the planet? And that if you want to reach herd immunity, at a minimum, you need to vaccinate about 60% of these people. Therefore, on the back of the envelope, you can calculate how many doses will be needed. And then you can think, well, how do we produce these doses? Well, Astrazeneca, Johnson, Pfizer, Moderna, and all these companies, between them, they will produce enough for all these billions of people. Again, on the back of the envelope, you don't have to be a specialist or anything to know that these companies can't. It's a simple thing. And yet nobody thought about it, or nobody planned anything like that last year or this year or now. So we still don't have a global plan to vaccinate the world. When COVAX started, when they invented this COVAX, the idea was that COVAX will be like a purchasing mechanism for the whole world. That everybody, the people who have money will put money, will buy by their own money, and those who don't have money will have donors' money to fund their purchase of vaccines, and then it would be allocated according to the WHO fair allocation, which is like, prioritize health workers and all people, that prioritization that we know across the whole world. So vaccinate health workers in the whole planet, then all older people in the whole planet. Of course, it didn't work like that. And because we come to the second problem. So first problem, inadequate supply. Second problem, unfair allocation or hoarding, whatever you want to call it. So basically, you have money, you buy, never mind everybody else. And therefore, the result is what we have now. Over 6% have been vaccinated in the UK. 1.5% are vaccinated in Africa. So where is the logic in that? Anyway, should it be like that? No, it shouldn't. Even now, it shouldn't be like that. Because if you want to vaccinate the world, you need to increase production. You need to maximize the production of vaccines. How do you do that? By sharing technology, sharing knowledge and technology between those who are holding the right to this knowledge and technology, and those who can make the vaccines. So a couple of weeks ago, at the WHO World Health Assembly, the Minister of Health in Indonesia said that the Indonesian companies can make 500 million doses a year. 500 million a year, okay? So that's just one figure. And that doesn't include the other companies that can do that. But we're shutting them. I mean, not we. Companies are shutting that opening. And it seems like these rich countries are content to leave three vital decisions in the hands of pharmaceutical companies. How much, or the volume that you produce as a company, that is a company's decision. So the company can say, my capacity is 100 doses a day. That's it. You can push them to increase. Well, maybe they can increase it to 110, for example. I'm just putting figures. You can't push them more because that is the capacity, you know. The second question is the second decision that's in their hands is allocation. So basically, they will sell to the highest bidder. So if the US is paying, I don't know, $20 and the UK is paying, God knows what the UK is paying, it's all secret. Paying, I don't know, let's say again, you know, $20 or $30 per dose or whatever they're paying. Why should they go to COVAX? Why should they provide to South Africa? Of course, when they're getting higher money, higher price, and therefore huge profit. We talk about billions now of profit, billions with a B of profits for those pharmaceutical companies. So allocation is in their hand. And third one is price. They decide what the price is. Yeah, of course, the UK negotiates and with the company and the US negotiates with the company, but it's not a negotiation on equal, even for rich countries, it's not equal, it's not negotiation on equal terms because the companies knows everything about the country. They know how much the country needs, how desperate people are, all these things that help in making a decision. You come to the government doesn't know the real cost of research and development. So if the company says this product um, um, costed me $100, they just have to take it. That's $100. They can't open the books and see, was it really $100 or was it $10? So now we have some studies that show that the cost of making a number of vaccines is far, far, far less than the prices that are offered to COVAX as like at cost price, non-profit price, $10 a dose from Johnson & Johnson and some others. We don't know if it's not cost. So these three vital decisions, production, allocation, and price, are in the hands of pharmaceutical companies. And they hold the knowledge. The key to the knowledge and to the technology is in their hands. So nobody else can do it. Nobody else can do these vaccines unless the company has a goodwill of going to make a commercial agreement with another company. Now, at the G8, Boris Johnson was just going, you know, he was talking as if they saved the world, as if they vaccinated the whole world, really, about how wonderful Astrazeneca deal with in India was, how wonderful. So, you know, he was encouraging or promoting that other companies do the same. What is the Astrazeneca deal is? It's a commercial deal, therefore it's secret. Therefore, we don't know what's in it. What we know is when we see the outcomes of that deal. So we knew that the deal didn't have anything about price. When we saw that Serum Institute is selling the vaccine to South Africa at the time when South Africa bought it for over $5 a dose, when they sell it, when AstraZeneca itself selling it in Europe less than $3, and they're selling it in Brazil for $5.2 as well, and in Uganda, a low-income country, for $7. So that's one thing in that wonderful deal. The other thing we didn't know until we saw the result was, so Africa at the time had basically less than 1% of people vaccinated. Africa hadn't vaccinated health workers. And yet the UK was vaccinating people under 50 years old, so not really at-risk people. And yet they had there was some shortages or something in the UK. So they took 5 million doses from serum in India. And then we realized that in this wonderful deal, it actually prioritized AstraZeneca's request. So AstraZeneca at that time wanted to satisfy their contract with the UK. Never mind what happens in Africa. So the doses went to the UK and not to Africa. So they went to non-at-risk people in the UK rather than hugely at-risk frontline health workers in Africa. So this is the wonderful deal they talk about, a commercial secret. What the people's vaccine is calling for is what Dr. Tedros from WHO called a coordinated mechanism, sharing knowledge in a coordinated mechanism. And what is this coordinated mechanism? More than a year ago,
Moga, you have
last
yes,
minute, last thing.
you have 1 minute left. Yeah.
Okay, so just a year ago, WHO and Costa Rica set up something called COVID-19 Technology Access Pool, which is based on the medicine patent pool. So basically, the companies that have the technology, they share it there. That pool license or transfer the technology to other potential good quality companies that can produce the vaccine. That way you maximize production in the whole world. And of course, when you have many companies producing, the price goes down because you have competition. But not one single vaccine producer joined that. In fact, pharmaceutical companies rubbished it, and countries, the governments are not doing anything about it, except the UK. When they oppose the waivers, they say, oh, we have voluntary mechanism like the pool. Oh, hello, what are you doing about the pool? Nothing. So we will continue campaigning for technology access pool to share knowledge, to enable manufacturing, to enable supply, and for supporting the TRIPS waiver to waive intellectual property. So with these two, you can have manufacturing.
Thank you very much, Moga, and also thank you for giving us examples of what has happened with the distribution of vaccines, and also pointing out how important it is that we put pressure on drug companies to be more transparent in order to give us more power to negotiate for fair deals. Our final speaker can't join us live, as you have heard, because he's based in New York, where it's now in the early hours of the morning. But Kayum Ahmed has sent us a short video with his remarks. Kayum is the division director at the Open Society Foundations in New York, where he manages the public health programs, global network, and access to medicines and innovations. He also leads OSF's cross-regional people's vaccine campaign, and we're going to listen to his video now, and after that we're going to move on to our Q&A session. Just before we play that video, just to remind you that you can leave a comment in the chat box or also in the Q&A section on the Zoom screen that you have, or if you're joining us via Facebook, you can leave a comment on OSF South Africa's Facebook page. We'd love to hear from you. OSF South Africa, you're going to play that video now.
Good morning, everyone, and thank you so much for inviting me to participate in this distinguished panel on vaccine justice. I'm really sorry that I'm unable to join you in person due to the fact that it's 4 a.m. in New York as you watch this video, and believe me, no one needs to be subjected to me at 4 a.m. As may have been noted in the introduction, my name is Kayum Ahmed, and I serve as a Division Director at the Open Society Foundation's Public Health Program here in New York. The Public Health Program has been at the forefront of advancing the concept of vaccine justice within Open Society, recognizing the shared sense of urgency to continue responding to the pandemic as we undergo an internal organizational transformation process. We see the concept of vaccine justice as seeking to address the racial, gendered, and colonial roots of inequitable and profit-driven COVID-19 responses. Vaccine justice recognizes the historical misuse of public health technologies and seeks to challenge and transform the dominant approach to development and manufacturing, financing, and delivery of diagnostics, vaccines, and therapeutics. And so the Public Health Program has identified 3 opportunities that we believe could contribute to advancing vaccine justice. First, we believe that shifting the power over vaccine manufacturing and development from global north to global south is an essential component in decolonizing the vaccine. Second, we argue for a radical shift in the model of vaccine financing and distribution, from a charity model to a shared global public good. And third, we argue for the need to shift the focus of vaccine delivery and uptake from overcoming individual vaccine hesitancy, as it's referred to addressing structural inequalities, which we believe is at the heart of vaccine hesitancy. And so I'll start with this third opportunity on vaccine delivery and uptake. And what we've witnessed is that media coverage and accepted narratives of this idea of vaccine hesitancy obscure the structural and systemic barriers impeding access to COVID-19 prevention and care, and often fail to recognize the power of disinformation in creating wariness and doubt. Communities most at risk of COVID, including health workers, people in crowded and racially segregated neighborhoods, and refugee camps, face barriers that go far beyond their acceptance or not of vaccines. And so vaccine disinformation, rather than vaccine hesitancy, has emerged as a significant front in the effort against COVID-19. Disinformation has been shown to reduce vaccination intent while also strengthening the hand of diverse enemies of open society. And so at the Public Health Program, we argue that focusing on disinformation while simultaneously addressing the structural and systemic barriers to access may be more beneficial than focusing narrowly on vaccine hesitancy. Secondly, we argue for a radical shift in the model of vaccine financing and distribution from a charity model to a shared global public good approach. We've noted the limits of the COVAX model, which is rooted in a global health architecture that leaves control with northern countries and donors. And this has inspired regional bodies, such as the African Union, to build their own agency and capacity when it comes to public health and pandemic response. This is taking place just as global health activists and the global health field has been inspired by the Black Lives Matter movement and mobilized by the profound vaccine inequity between rich and poor countries who have been calling for the decolonization of aid and of global health more generally. And so we therefore argue that multilateral agencies and international financial institutions such as the World Bank, who fund vaccine procurement and rollout, must ensure the effective engagement of national level stakeholders, including civil society, helping to push for greater equity of access of vaccines, particularly for marginalized populations. And this, we think, marks a sharp change in practice where there are barriers to entry for civil society. On the third dimension around manufacturing and development, our theory of change recognizes that the vaccine is not simply a biomedical technology. It is also an instrument of political power. And so our theory is rooted in decolonial, anti-racist, and intersectional discourse centered on advocating for a new public health order. The urgent short-term response to the COVID pandemic must be located within a long-term vision of a new public health architecture. And so to challenge the existing global health framework, we seek to firstly de-link from Euro-American constructions of knowledge and power that reinforce the profit-driven biomedical system. And second, advocate for the reordering of systems of power by strengthening global South research and development and manufacturing capacity. So in conclusion, vaccine justice moves us beyond narrow vaccine programs to include the pursuit of fair and inclusive responses to the COVID-19 pandemic now and in the future. Vaccine justice stands for the notion that the COVID-19 vaccine should enable people to realize their human rights, not deepen existing inequality. It recognizes and seeks to rectify the histories of injustice that underpin inequitable access to vaccines and other COVID prevention measures. Thank you very much.
Okay, now we're at the end of that video and some great messages and suggestions of solutions of how to address inequality. We're now going to move on to our Q&A session, and thank you for those of you who have left questions and also made comments. I would like to start off with a very interesting comment and question about a recent event as early as last night when we heard Julius Malema from the EFF refusing to comply with lockdown rules until there are enough vaccinations and until frontline groups such as the police have been vaccinated. And the question relating to that is, what is the link between morality of a state or a government, such as the South African government, and the behavior of citizens? What happens if they feel their concerns are not being addressed within the context of vaccine justice? And I would like to ask Ames, Lauren, and Tlaleng to respond to this question. Can we start with you, Ames?
Thanks, Mia. You know, it's quite a complex situation. What we've seen in terms of the situation in South Africa is, you know, a move towards the extreme when government does not come to the party. So, you know, we've seen civil unrest. We've seen demonstrating, burning down, burning tires, etc., in the so-called townships when there isn't the service delivery. So I would liken what Malema has suggested with what seems to be the general trend in terms of drawing government's attention to a situation. But having said that, I think that that's a very immature approach. It's a very uninformed approach as well. And I wish that as a so-called leader, he would take the time to understand why we are where we are at the moment. So rather than demonstrating and ignoring Ramaphosa, maybe Malema should go to the World Trade Organization, and he should go to he needs to go to the pharma industry and take all his demonstrations out there. Maybe that would be of greater impact. But, you know, I think it's important that, you know, I talked about the morality of governments with regard to equitable access. I do not believe that what is being proposed will actually lead to equitable access. What it will do is it will enable the positivity rate to go well beyond the 21% that we saw last night. And then would Malema then take the responsibility of initiating a genocide? I think we need to look at it in that way.
Thank you, Ames. Tlaleng, let's move on to you. Ames has pointed out there are reasons why we are here in this situation. I, as a journalist, have often felt that those reasons are not consistently communicated by the health department, that it's hard to hear that information, and that could possibly contribute to this type of suggestions of and frustrations of how people out there reveal their frustrations. What is your input on this, and do you have, you know, your opinion on Malema's suggestion, but also on how could we better address this? What is a better solution to, if we wanted to communicate our frustrations to government?
Hi, Mia. So I am wearing the UN Special Rapporteur hat, right? So there's a certain way I need to approach this issue. So firstly, we need to reaffirm in all the spaces that we are in, you know, whether it's through these webinars or in person, but also definitely in how many of us use social media to promote access to information. And I think COVID-19 regulations, from the hygiene messaging, the wearing of masks, the social distancing, all of those are really necessary. And most of those require some sort of behavior, right, from citizens. And I think where you have a country where for the last year and a half, I mean a bit now, you have absolutely no transparency. You only have statements of intent, right, from the health ministry. Halfway through, you find out that there is corruption and maladministration allegations on the very person who's supposed to be leading, right, in this COVID-19 response. And I think citizens are frustrated. You know, the frustration is not just expressed in sophisticated manner. Sometimes, you know, people say what they say, but we hope that they understand, right, the positions that they occupy, and that without a doubt, we all have to adhere to those regulations. But in absence of transparency and accountability and an actual plan for vaccines, you can only depend on citizens for so long. And remember how even with the initial hard lockdown level 5, many of us were saying, it's fine to put the country on level 5, but you need to be doing other things in terms of the national health and to actually make sure that the system is efficient. And that still hasn't happened. And we're a year and almost a half into the pandemic in South Africa, and there's been no shift forward in terms of honesty, right, about also what the difficulties are. And I think it's quite frustrating, and I can imagine when you see your leader, right, in a global space like G7 and other leaders and from other nations, they have a press conference, they share what the details of the discussions were, they share with their nation, you know, why them being there is for their benefit. But here you have the reverse, where the president doesn't take any questions, they don't respond to any letters. And yes, he was at G7 as an invited guest, and then what did that mean for us? How far are we with waiver trips? Is he holding his counterparts accountable? And just yesterday, we hear that the French government is planning to bring their own vaccines for their own French staff in South Africa. So the issues are not about who's more sophisticated in showing their displeasure of the situation. But what we do need to do is hold the government accountable, because they are ultimately responsible for giving people information, for ongoing patient health information, and again, being honest about, do we actually have a vaccine plan or do we not? And if we don't, what are the issues, right? And I think it's very frustrating, again, when we talk about COVID-19 only as a biological issue. COVID-19 has really compounded existing inequalities, and where you have women, for example, who were heading single households, right? And they went on hard lockdown. We know women are already paid less for the work that they do. Women already enter the job market lower than their counterparts in terms of men. So when you go on a hard lockdown, and the stipend or the 350 rand in social support only trickles in 6 months later, what has happened to those people? And I think for me, those are the questions that I want to know. Politicians will always be politicians, but I think at the end of the day, we need to hold everybody accountable, and not just those who we seem unsophisticated or looking like they're hooligans, as people will often refer. But I think we need to actually put the accountability where it belongs, and it belongs with government. And they need to counter any misinformation around regulations. They need to counter any other one of their counterparts, because I assume, I mean, he's an MP as well. So, you know, there is a level of you know, common leadership there, and they must hold each other accountable. And you don't see this even in the global space. You don't see leaders holding each other accountable, right? Whether for the Security Council decisions that they take, whether around issues of corruption and maladministration, around racism. I mean, people are worried about a vaccine passport. I mean, many of us who are Black people and people of African descent know that you can't even visit half of the countries on this planet just because you are Black, right? And if you want to, some countries are still demanding even an HIV test because you are Black. So I don't mind carrying just another extra piece of document, for example, because all my life I'm used to that. So there's a privilege, again, in terms of what people think is fair or not fair. From where I stand, just as a person, a vaccine for COVID-19, you know what, just added into another million things that I need to prove. before I can travel anywhere. So we need to talk about the remnants of colonialism as well as apartheid, about controlling the movement of people, policing of people, and how that now, because it's affecting the richer countries, it's affecting the so-called global north. Now suddenly vaccine passports are this big problem. But we've had inequities and discrimination and racism in the visa processing anyway all along, but because it wasn't affecting them, it wasn't a problem. So we have to be aware of where we are in terms of positionality on many of these issues. But I still think we have to be strict about communicating the healthcare messaging, and anyone who communicates different has to be held accountable, whether it's a political leader, whether it's just another person on the internet. But I think we mustn't shift responsibility in a lopsided manner, right? We still have to remember who's in charge here. And Malema is not in charge of government or governance. So how do we get to a point where people are so absolutely desperate and they will protest anyhow? And I'm very wary of policing how people show their protest. But absolutely, as a medical doctor, as just a person who understands how COVID spreads, of course, we must adhere to the COVID-19 regulations. But how long will we just do this ping pong of open up, lockdown, open up, relaxing? How long do we do this for when there's no honesty and there's allegations of corruption in this very department that's crucial? Thanks, Mia.
Thanks very much, Tlaling, and thank you for pointing out that how we view equity is so important. Our backgrounds determine it in terms of how much we had access to certain services in the first place. In other words, what we compare it to. So Lauren, I would like for you to respond to one of Tlaling's points, and that is, how do we hold government accountable for good vaccination policies and for vaccine equity, but in constructive ways that wouldn't make the virus spread in the country, but still hold them accountable? And how do we get leaders to hold each other accountable?
Thanks, Mia. I mean, I think the question of accountability is an important one. I think it's one that's been complicated in the context of, again, the lockdown, right? So the lockdown and also the electricity crisis that we're going through. And I say that because under current conditions, we have limited opportunities to get together, to talk, to organize, to mobilize. And generally, the people that can get together are the ones that have access to data, to electricity, to charge their phones, to airtime, and so forth. So I think that's, and beyond that, if you want to get together physically, to travel, to do the tests by the PPE and so forth. So, I mean, I guess the one point I'm making is that accountability is complicated by the fact that mobility is restricted. We know that it has a disproportionately negative impact on women who suffer from restrictions in mobility, in any case under so-called normal circumstances. And so I think at a very basic level, that's something to take on board. I think the other part of it, and this we saw during the hard lockdown, was a kind of militarization of responses to public gatherings and public meetings. And I think that's something that complicates being able to come up with a kind of common agenda, right? The other thing that I think complicates accountability is that you're dealing with a situation where legally pharmaceutical companies, who are the big players in this landscape, don't have to share information. So we know, for example, in 2016, there was a UN special panel on access to medication. And one of the key recommendations to come out of that panel was that pharmaceutical companies should disclose information on the cost of the pharmaceuticals that they were manufacturing, on the cost of the research and development prior to that, on the costs that they spend on marketing. And of course, what we know is that none of that has come to pass. And these are not requests that are recent. We know from the South African context that mobilization around access to antiretrovirals, a big focus of the litigation was on getting access to information about the costs. So I think, you know, one of the things perhaps to push politicians on is to disclose the information they have, and also to do high-level advocacy, not just around the TRIPS waiver, but also around issues related to research and development financing, procurement, and so forth. I think that's a key part of the puzzle that's missing, and that, you know, we can't make decisions about what's fair in terms of a profit margin if we don't know what the costs are that go into drug development. And then maybe, you know, for politicians to hold each other accountable at a third kind of global governance level, there has been a shift from making decisions about things like vaccine access, from making decisions about those processes within the World Health Organization into organizations that are basically partnerships between WHO and private sector entities, so Gavi, CEPI, COVAX, where member states don't really have decision-making power. A lot of the decision-making power is distributed between big philanthropic organizations, kind of technical experts, and then these semi-public-private entities. And so I think really at the WHO level, then there is an argument to be made to make WHO the key decision maker in global health governance, the key decision maker in terms of, for example, how vaccines are distributed, which currently it's not. In terms of COVAX, it's kind of a technical and implementing agency, but decision-making power lies by and large with the chairs, which are CEPI and Gavi. And I think that's a problem because it effectively amounts to a de-democratization of global health governance.
Thank you, Lauren, for your input and insights there. We have a comment and also a question from Sabelo Molefi, which I would like Norco as an information expert to respond to. And Sabelo points out that in rural districts where people generally have less access to information and where English information is not going to get you very far, there are many people in his community who argue, why should they get vaccinated? If you can still get infected once you have been vaccinated. And that is, of course, true, that vaccines don't entirely protect you against getting infected. We don't have a lot of information on that for COVID vaccines at the moment. We've got a lot of information that tells you won't fall ill, or it reduces your ability for that significantly. But we've got less information on how vulnerable you still would be to infection. Now, how do we, this is a situation of inequity. People in rural areas have fewer resources, less access to information, but this is a complex sort of piece of information that you need to communicate. How would you do it? How would Africa Check do that? And how would you think the government needs to do it?
Yeah, I mean, so this is exactly the sort of collaborative approach that is needed to solve some of these issues. And the point I was making earlier is that you need to have public health authorities that take charge of the messaging and sort of look beyond the sort of digital bubble in terms of spreading information. And partner with other players such as community radio stations, for instance, in getting some of this messaging out and communicating some of this factual information to communities that are not on any digital platforms, do not even have access to data, cannot even afford data. And so it's important to have very collaborative strategies and approaches that look and aim to take the information beyond the digital bubble. So at Africa Check, we're exploring a partnership at the moment where we're working in Nigeria and Senegal to partner with radio stations to push the sort of pre-banking information, so good information, to push good information into communities using radio and radio drama. It's an experimental approach at the moment. It also gives us an opportunity to interact directly with communities around this information and how they understand the information, and they have an opportunity to engage with us or experts that we rely on in probing further and getting better clarity on some of these key issues. So the point I'm making here is that we need to encourage the public health authorities to start looking beyond Twitter, Facebook, all these social media platforms, to start looking beyond these platforms that are not accessible to everybody, and start getting into the communities and using an example being community radio as an access point.
Thank you very much, Norco. I'm now going to move on to procurement of vaccines and what works the best for us to get access to as many vaccines as we can in a country. And I would like Moga to respond to that. There have been a lot of comments in the chat box about, for instance, in South Africa's case, why did we not get access to more vaccines? And in our case, the situation is, of course, complicated because we've got the beta variant here, and we can only use vaccines that we have data for that shows us that it works. And we've had the situation where Astrazeneca data showed it doesn't work so well against mild and moderate COVID. We don't really have information to show what it would do by the beta variant COVID, that the beta variant causes when it's severe COVID. And we've only had J&J and Pfizer here, for which we have some data. We are very interested in having Moderna, but Moderna has made it very clear they don't see us as a market. So what would be the correct approach in a situation like South Africa, Moga, where we have had lots of disruptions, some of them, many of them out of our control. For instance, the recent J&J situation where there was batches that we couldn't access because of complications at a US factory. What should we have done better? Because if you look at the implications of that US factory in a country like Canada or Europe, it's not as severe as in South Africa because they've got so many other vaccines to rely on. But here we only had Pfizer vaccines left. Could we have done something better, Moga, in your opinion?
Okay, so sorry, I can't use my camera, you're blocking me. So basically what happened for all developing countries, South Africa included, is that it seems like the countries waited for COVAX because COVAX was supposed to deliver and people believed in it. Well, that was a big mistake. That's a global mistake. That's not a South Africa mistake. So then countries started to think, oh, well, I'm not going to wait. So they've gone ahead and did bilateral deals. South Africa did a bilateral deal with Serum, Astrazeneca, and then we discovered, you discovered that this beta variant, this story, that the beta variant is not as responsive to the vaccine as the alpha variant or the original virus. So what else is available on the global market? This is the issue. Pfizer kept saying that, you need this highly sophisticated cooling mechanism. So the vaccine is basically, they were saying, and Bill Gates was saying, kind of almost saying the same, that it seems that that vaccine is not suitable for developing countries. You have the AstraZeneca vaccine and be quiet. So I remember from the beginning, Dr. John, the leader of the Africa CDC, was saying that the majority of infection at that moment was in the capitals, basically, of African countries, and therefore you can have the sophisticated cooling mechanism in a big hospital and get people to basically queue to be vaccinated, but nobody listened to that. So what South Africa or any country had in the market was AstraZeneca, Pfizer with the cooling problem, and Pfizer not willing to kind of cooperate and sell to developing countries. Pfizer being the worst on negotiating indemnity and liability, And they wanted in Latin America, they wanted government assets to be under their control to guarantee, as a guarantee. There was some talk that they wanted an airport to, I mean, it really is crazy the way they negotiate. And then you've got Johnson and Johnson. At the time, it wasn't, the vaccine hadn't been approved. Then you've got the Chinese and the two Chinese vaccines and the Russian vaccines. At that time, none of these three vaccines was approved by the WHO. So some countries went ahead and approved the vaccines by their own drug regulatory authority, and bought it and paid for the vaccine, like Morocco. Some countries said that we will wait to see to have some guarantee on the quality of the vaccine, the effectiveness, the safety from WHO. So they waited. Now we have the two Chinese vaccines being approved. The Russian vaccine still not approved by WHO. They're still lacking data from the company. The company says they put the data and WHO is not doing it. WHO says we haven't got the data. Anyway, so the result is that the Russian vaccine, we don't know if it's effective or not, according to WHO. So at the moment, you've got the two Chinese vaccines that we can, that South Africa and others can buy them. I can appreciate why South Africa didn't buy the Chinese vaccines. As I said, they were not approved by stringent regulatory authority, like a strong regulatory authority. And our regulatory authority, as it were, it's not really a regulatory authority, but it kind of gives similar approval, is the WHO. And WHO hadn't approved the Chinese or the Russian, so South Africa couldn't buy them. So in a way, we were in Africa, including South Africa, we have been, to some extent until now, to be honest, still under the mercy of pharmaceutical companies.
Thank you, Moga. It's a really complicated situation.
Yeah.
We have 5 minutes left, and I would like to end by, I'm going to just choose two panelists because of the lack of time. I would like to ask Tlaleng and Ames Dai to each tell me if they had to launch a vaccine justice campaign in South Africa today, what is the one issue they will focus on first and that they think would be the most vital to do? Tlaleng, we can start with you.
Okay, so if we actually had vaccines, is that the question?
Yeah, or if we don't have vaccines, if you had to launch a vaccine justice campaign, whether that's for access to vaccines or for equal access. Yeah,
I think for me, it's very important to have transparency in governance and leadership, all the way from national, provincial, district, and community health. We need to collect data that we can actually use. So it needs to be quality data that can feed into the quest for justice. And thirdly, we do have to have accountability, because without transparency and accountability, there can never be trust from the population. And I think that's what South Africa is desperately needing right now. They need to trust their government again, that they have their best interest in heart. But I think to gain that trust, you need to be transparent, and you need to take accountability and get rid of maladministration and corruption in the health system. And again, one of the biggest things is that we need to remember that we have to hold businesses, including pharmaceutical companies, to the guiding principles on business and human rights, because they are not exempt from exercising human rights due diligence in their work. And that would be my other thing that I would do. Thanks, Mia.
Thank you very much, Tlaleng. So Ames, transparency and accountability, what would you focus on? That's Tlaleng's issues. What would your issues be?
Absolutely. But I think for this, we need meaningful community engagement, and meaningful community engagement at all levels, including the level of our Goko in rural KwaZulu-Natal and elsewhere, is so important. So this communication must reach our remote rural areas as well. Meaningful community engagement would, like Tlaleng said, result in transparency and therefore integrity, maybe trust and integrity of our leadership could be reestablished. Because we really need, I think, for our vaccination campaign and for our vaccination rollout to be successful, we need everyone's involvement. And we need this involvement in an open and transparent manner. I also think that our leadership, the campaign would need to get to the highest levels, to ask, to urge our leadership to come down to our levels and sort out this bridge, this disjunct between the state actors and people on the ground. Because there's a lot going on in the background that is just not permeating down to the public. And perhaps we would not have such an angry and also a frustrated public if there was adequate communication. Having said that, I must say, I cannot not say, it would be ethically incorrect of me to leave this out. And that is, what's happened to communication through Department of Health? We all know what happened to the funding. And I think we cannot ignore the fact that we have been terribly let down in terms of the digital vibe saga. And there's a lot to be done now to actually regain trust. Thanks.
Thank you very much, Ames. And I think that is such a strong message that you're ending on, for our leadership to come down to our level and wipe out the distance between us and them. And then to also look at the impact of corruption on their ability to communicate. That brings us to the end of our webinar today. I would like to thank all the panelists for their time and their insight and their participation in this webinar. And I'd also like to thank OSF South Africa and particularly Jonlyn van Reenen for organizing this webinar. And then there are a few other people, Shiwa and Executive Concierge for the logistical arrangements, Ryan from Plugged In Productions for technical assistance, Rosalind Daniel from Bhekisisa for helping me to keep track of your comments and your questions, and then the team at Pomegranate for social media support. If you'd like to access a recording of this webinar, it will be uploaded on the OSF South Africa website. You'll be able to access it there. I'd like to also thank all participants for your questions, your comments, and for being part of this discussion. This is the end of our webinar, and it's goodbye from me, Mia Malan.